Hello, everyone, and good morning. Welcome and greetings from New York, a beautiful day in New York. My name is Lori. I'm with Orbis, and I have with me here today a wonderful panel and a wealth of knowledge. Tom Terranova, Dr. Monte Goldstein, and Dianne Bourque, all here from the American Association for Accreditation of Ambulatory Surgery Facilities. And we're here today to talk about infection control. I'm going to share my screen for you. So today we're going to talk about infection control and ophthalmic nursing. Some brief just overview of the main aspects of infection control. And then we're going to go into a panel discussion, and we're going to utilize all of our panelists here, and we're going to go through some questions that came in during registration. And we're going to go through some of the questions that you sent in, as well as see if we can answer some of the questions that you may have during the webinar. So we're going to talk about infection control and infection control plan, program. We'll go into a little bit of TASS, and then we'll have a panel discussion and talk about a few viewpoints in infection control. Lawrence, if you want to put up the first poll question, that would be great. So I'd like to know from everybody, do you have a written plan or a program or any type of policy that guide you in your infection control practices? A written plan, something that you go by, that may have been approved by your board or your nursing director. I'd just like to know, who out there may have a plan. Very good. That's more than I expected. That's fantastic. Good to hear. Okay, that helps a lot. Thank you. All right, so let's talk about an infection control plan, okay? A plan or any type of policy. So this is something that's going to guide you and assist you in preventing the transmission of infectious disease among your patients and among the staff as well. It can promote patient safety by reducing the risk of acquired and transmitting infections. So this is an actual plan. And what we're going to go through in the next few slides is kind of talk about the components of an infection control plan. These are just guidelines and something that you can put in your plan to just help. So really the goal is, if I was brand new and I was a brand new nurse coming onto your facility, I can sit down in front of this infection control program and this plan that you have and be able to know exactly what you do to prevent infection in your facility. Just by looking at your plan and your program, it's going to guide me as a brand new staff member, guide me into your infection control practices. So some suggested components, and Dianne, you can let me know if there's anything else here that you think we may be able to add. But the first thing you want to do is you want to identify your team members of your infection control program, a coordinator, someone in charge of that program, someone that's going to help facilitate infection control in your facility. It doesn't have to be a physician. It could be a nurse. It could be anyone that you feel is qualified. And qualified could just mean someone that may have taken some classes, some online courses, or have learned about infection control, continuing education, and that can help put this program together and can help monitor it. And some of the components are things like hand hygiene, the use of personal protective equipment, medication and safe injection practices, environmental cleaning, sterile processing, of course, COVID-19. And you want to set goals, especially when you're doing an infection control program. You want to set goals like, okay, we want to maintain 90% hand washing compliance, things like that you can have in your program as to goals and objectives you can do it annually. Training and education is huge. Monitoring, making sure that your program is working. Are there any pieces to it that we think, we could enhance or remove or do better at? And then there's reporting out to your board, reporting out to your committees as to how well you're doing in infection control. And if there's anything that you may think of that could be action items that you could do better at, or, anything as far as training, any training that your facility has had in infection control. These are all things that you may want to report out just so we can do better. So we can look at it and say, yes.
Lori, and I think it's really important that you identify a person who has an allotted amount of time to continue throughout the year to stay updated to regional recommendations, and also to, have more time to read up and communicate with the staff. Like you said, the monitoring, very important with hand hygiene, monitoring that staff is utilizing the PPE effectively, performing environmental environmental rounds, we really do believe that if you can do that at least monthly, you're going to see the holes of where your staff is not enacting the infection control plan appropriately. So that's very important. And like you said, on training and education, it's really important to validate competency for the staff members that are performing really high risk practices like your sterile processing. So you want to make sure, like that new, the new hire, you would watch what they're doing and really validate their competency in all those key areas. And then also that infection control or coordinator is going to be speaking with the surgeons in your facility and making sure that they are monitoring for any surgical site infections on a monthly basis. And if there's any implants, making sure that they're actually looking throughout an annual, period of time, 1 year, to make sure that those infections are being reported so that you can track anything that's going on in the facility, and then do some performance improvement, actually, changing some things to make sure that the facility has, safe practices. So just wanted to add that just a little bit.
That's
because
excellent.
That infection control coordinator is just a key member of the team.
It is so, you're right. It is so important to make sure that that person has the time to coordinate and has the time that's needed and necessary to put into a program. So giving the role of infection control coordinator to your director of nursing, or someone that just may not have the time to really monitor and put into it, you want to make sure that that person has that time that they can set aside to put to it. That's so excellent point.
And we'll also like to make sure that that infection coordinator meets with every new hire and kind of goes over, make sure that they understand the plan, because, especially if it's a new nurse or a new staff member, just making sure that they understand, having that time. Thank you so much.
Thank you. Let's talk a little bit about hand hygiene, okay? And then your availability of soap and water, or you got your alcohol-based hand rubs in all your patient care area. They have to be accessible for you. And let's talk a little bit about when it's performed. And these are things you can have in your program, things that you can monitor for. Make sure you're monitoring your staff, before and after direct patient contact, after removing your gloves, if you have contact with bloodborne pathogens, even if gloves are worn, okay? When your hands are visibly dirty, that's always that difference between soap and water and alcohol-based rubs. If your hands are visibly dirty, you're washing with soap and water, okay? After you're using the restroom, and of course, after any type of cleaning in your facility. So these are some of the components of hand hygiene. And then you have hand washing audits. Diane, thank you for this audit tool. So this is just an example of what you can use to audit and make sure that your facility is following hand hygiene, okay? Observation, you can assign it. It doesn't have to be that infection control coordinator all the time walking around, because of course everyone's going to know that that coordinator is there walking around, making sure that you're following hand washing. You can assign it to a different staff member every month, or however often that you do your audits. Your operating theater, pre-op, recovery, don't just make it all about the operating room. Hand hygiene is important in every aspect of perioperative care. So anesthesia, your physicians, make sure that you're monitoring everyone, and you can use a type of monitoring compliance audit tool. Here is one for your reference, and at the end of this talk, we'll give you some means for contacting us if you'd like examples of any one of the tools that we're using here. Quad A is great at offering their resources. And how often should you be doing audits? It's in your policy. That's up to you. There is no standard. Some people do it once a month. Some people do it quarterly. Especially if you find that you may have problems with hand washing audits, you may want to do it, more often than not. And then you got your tracking and your trending, okay? Your compliance. Let's look at your percentage of compliance. And then you're going to report it. You're going to report it to whichever regulatory body that you have, whether it's the board of directors, board of management. I'm used to a patient care assessment committee, anything like that. But you want to make sure that you're reporting the outcomes. You're looking at your percentage of compliance, and then you're auditing to make sure that, okay, how did we do? Talk to your staff members. Say, all right, we did, you don't have to call anyone out or throw anyone under the bus, but you can just say, you guys, this is where we're at for hand washing. It's great. It's not so great. And include your team, right, Diane? Include your
Ab-
team, put everybody together and include everyone in that.
Absolutely. And if you see that someone is really, needing a little help on that, a little reminder, sometimes a peer coaching can be effective, if especially, and just to say, if there is a physician or surgeon that needs a little reminder, sometimes that comes a bit better from a peer. It's great if the infection coordinator can be effective, but it just happens, and we just want to make sure it is addressed so that we don't have problems with that. But you should be in the very high 90th percentile. Thank you.
And you got education, so important. Infection control training and education. So how often should you be doing your training in infection control? Upon hire, always, when that person comes in, as Diane had mentioned, that person's going to sit down with an infection control coordinator, and they're going to look at your plan or discuss infection control, so they have the right expectations of what is expected of them and what your policy is in your facility to keep infections down. You have annual continuing education. You could do that, once a year, beginning of the year. Everybody has to undergo training. Also, when your compliance is low, if you do have a low percentage, let's say of hand washing, let's start that training again. And any new protocols that are put in place, like if you have new disinfectants or new equipment, anything like that, you want to make sure that you're as well going through training to make sure everyone's expectations are correct.
And Lori, what we learned, in the last 2 years is when new protocols are put in place, it's really important to bring the staff together. When COVID happened, my goodness, that just changed our world. And we had new equipment that we weren't used to using. I mean, obviously we were hand washing and we were doing environmental disinfection, but we put it into hyperdrive. So those are the things, if there's any new emerging infectious diseases or anything like that, we really need to have staff meetings and emails that are sent out, or posters that are put out, communication books, whatever we can do to make sure that infection control training is just going through the entire staff. You don't want to miss anyone. If they don't show up for the meeting, we need to have a way to communicate with people that maybe aren't present in that shift or on that day.
Yep, and think outside the box for these meetings. And everyone's so used to having after office hours, but honestly, we used to do our fire training and our infection control training in the morning before the day even started. We used to have everyone come in a little bit earlier because no one could stay after. So we had to think after the box. It's so important. Take the time. I know we're all so busy, especially some of these centers, the high volume centers, so you need to take the time. So.
Lori, Diane, if I could just insert a little bit of awareness that we gained through COVID, conducting surveys really kind of around the world. Keep in mind from a management perspective that anytime you add a new process or policy, or when there is a new risk that comes up, you're already taking a staff that has a compressed amount of time and compressing it even more. So when Diane's talking about that knowledge transfer and that knowledge retention for your new staff, the same thing applies here when you're talking about a new process for your existing staff. And that's why the training and reiteration and tools are so important, because you're breaking a routine that people have developed over 10 years of practice or maybe longer, and shoving it into a really limited time frame. And so people are now more rushed trying to remember a new step or a new process. And that's where we really saw the highest frequency of breakdowns in COVID-19 precautions, or in infection control precautions during COVID, was because it was a brand new thing in much less time that people were trying to retrain themselves on the run. And that's where those gaps happen. So reinforcement and kind of retraining is really important here. It's not just a matter of sending it off once and everyone now knows it and does it perfectly every time. As we all know, that's not how the world works.
And also, to reinforce that, what we found was really effective. Lots of visual cues and visual reminders, posters. I mean, everyone saw that. Please wear a mask, social distancing. But they do that because it's very effective. Hand washing, put those, the hand rub, putting that signage everywhere. It really does help reinforce things that we're trying to get into the muscle memory. It's not. We've disrupted the muscle memory, and we're having to add to that now. So Tom, that's really great information.
Excellent, thank you. So let's talk about a training method. How are we doing our training? All right, we want to choose a simple way to deliver the training. It doesn't have to be complex. It doesn't have to be a complex system. You could do a PowerPoint presentation. You could do videos. Please ensure that your content is up to date. Okay, just make sure everything that you have is updated and that it can be assessed by the individual at a convenient time. Okay, sometimes you can choose training on web-based videos that they can do from home, or they could do early in the morning, or they could do after hours. But you want to really work with your employees and make sure that you're providing them training that they can do and they can easily access it. And it can be kept at the healthcare setting for reference. But again, you could have meetings, you could have somebody come in and do a training, you could have web-based videos. However you do it, just make sure that it's a simple way to deliver the training and that it's easily accessible for your staff.
And Lori, I'm just going to interject one other thing is we're mostly talking to nurses and physicians here today, but there's also other members of the healthcare staff. There's our support staff, housekeeping.
Nurses
we need to
aid.
make sure, yes, and all of this information needs to get down to everyone in the facility. So, sometimes we often, when we go in and do a survey, we're asking for the infection control training, is it done differently for different members of the staff? And that's okay. The information just needs to be able to be received. So you may have different types of training, and that's okay as well.
Yes. You get your personal protective equipment. Okay, these are the specialized clothing equipment worn by an employee for protection against infectious disease. These are things like your gloves and your gowns, your shoe and head covers, and your mask, of course, and your face and eye protection, and what is worn for PPE according to your policy and your procedure that you have in place. So these are just some examples of appropriate personal protective equipment. And this is, again, something that you could put in your infection control program. And then the key factors to determining your appropriate PPE, what's appropriate for different settings in an intraoperative setting. Your anticipated exposure, okay, the durability of that PPE, and how it fits as well. You want to be sure that everything is fitting appropriately so that you can prevent infection not only to your patients, but also to yourself. So the staff knowing the right PPE for the job, okay, and being available and accessible in all the clinical areas. That is key. You want to make sure that your protective equipment is available. Dianne?
And Lori, that was really important because during COVID, we found that some of the supervisors, and they had to, were locking up, the N95s or K95 masks. And, so we need to make sure that it is really accessible to the staff on all the shifts, on all the days.
This is just an example of a grid. Dianne, you provided this. Could you give us an overview of what this is?
And this is just a little grid that helps. It's a risk assessment. And basically what we do is we like to take the areas of the facility and the staff members that may be in that facility and what's their anticipated risk. So if you have someone that, you can see right here for administration, if someone's working in the front office, they really don't have a lot of risk for blood and body fluids. And then, but you take someone that's in the OR, you're going to see, like here, the yellow, that their risk is very high. And in that column, it just, if they are in an area where there is a high risk, it just suggests, you need eye protection, you need a mask, you need a gown, you need a glove. So basically, as we're training people, you can kind of give them something to look at that says, okay, here's the grid. When you go into this area, please utilize every piece of this personal protective equipment. Because when we talk about PPE, we're always talking about protecting the patient, but here we're really talking about protecting our staff members, because if they get ill, we don't have them on our team any longer. So we really need to do a great job of protecting the team and reminding people, if you have a peer that's not wearing their mask or not wearing their gloves, just gently saying, hey, come on, let's do this. You need to be safe for yourself.
This is such a great tool, especially for new hires too. This is such a wonderful tool to have. And then you got your medication injection practices, definitely something that you should be putting in your infection control program. Instructions for use. I'm sure you've heard this many, many times, but it really is key to so much of what we do in a healthcare setting is instructions for use. Your manufacturer's instructions. These are the things that you really need to be looking at, really taking into effect, especially things like single dose vials versus multi-dose vials. Take a look at your vial. Not every vial can be accessed multiple times. Single dose vials really have to be discarded after use on one patient. Then you have your multi-dose vials, and they can be used on multiple patients if they're labeled and stored according to the IFUs. You have to take a look at those manufacturer's instructions and see how these medications need to be stored. Are they going to be refrigerated? What you need to do to make sure that you're safely using it on multiple patients. Okay, check your beyond use date. All right, it's put on the label when the vial is opened. And when that vial is open, you're going to have that beyond use date. It should not be stored in the immediate treatment area. Okay, so multi-dose vials should not be in the operating room. They should be outside of anything that you have in an immediate patient care area, and that includes the operating theater, patient bedsides, exam rooms. Okay, things like that. These are multi-dose vials, so you want to remove those from any patient care areas. And then if it is taken into an immediate treatment, it should be considered a single dose vial and then discarded. I know that sounds a little harsh and a little tough sometimes on the resources, but really if you want to prevent infection, these are the things you have to look at, is that, single dose vials are not meant to be used on multiple patients for a reason. And that's what we have to really look at for infection control.
And Lori, this is really important. This is something that as infection preventionists have been looking at for the last decade and really trying to push this message. Single dose vials, if they're just accessed multiple times, they don't have any preservative, and they really can start to, to grow organisms that you don't want to inject into someone else. One of the things that I think is really important is if you see on this photo, we have xylocaine in both vials, and they look somewhat similar, but I will tell you that I've seen many staff members that really don't know how to understand which one is multiple dose and which one is single dose. So I like to, as an infection control coordinator, show an example and say, look at that small print at the bottom. These look very similar, but if you open the one on the right, you have to discard it. If it's the one on the left, we can use the recommended practice of 28 days, label it, but it has to be stored and accessed in a neutral area. So in your facility, you want to find, is that the nurse's station? Is there a little room adjacent to the operating theater in which you can access those medications? And working with the staff members, because this may be something that they're not used to. We may need to talk with anesthesia and come up with a plan of how we can store these and utilize them effectively, especially with emergency medications. Anesthesia wants those right next to them, and we certainly understand why. But just talking with them about, this kind of new practice, because for many people, this is something a little bit new, especially on the immediate treatment area. They really don't have to, they don't understand this new protocol. So we just want to talk with them and make sure that we can facilitate their needs, but also stay safe.
Hey, Diane, I'm just going to interject on this one, and thank you. It really is great advice. One of the keys to implementing these recommended practices is getting leadership of the various disciplines to buy in. So in the case of anesthesia, and I'll readily admit I'm an anesthesiologist by trade, it is very difficult unless you have a leader that buys in and understands the protocols and really make it, his or her responsibility to disseminate that information to the anesthesia staff along with the nursing staff.
And sir, let me say one other thing. I say it very often, is that peer-to-peer conversations tend to be more easily received. So if you do have leadership that gets involved, sometimes it's a conversation surgeon to surgeon, anesthesiologist to anesthesiologist, that tends to be very helpful. But yes, you're right. Bringing all the stakeholders to the table and talking about the safe practices is so important.
It is, definitely. And as I'm looking at these flip tops, just something else to remember when you're working with vials is I see so often that everyone flips that top off and just immediately accesses that vial thinking, well, it hasn't touched anything, so I don't have to alcohol it. And that is not the case. Those tops come off, you alcohol no matter what. Okay, those tops have been on that rubber all this time. That's not clean. So make sure even when it's brand new and you're just taking that top off that you're alcoholing that vial right away. Okay. You have your environmental cleaning. So your standard cleaning, all right, beginning of the day, you want to do the sort of visual inspection of your area. And this is all areas, including, the operating room, everywhere, anywhere that you have a patient care area. Clean all horizontal surfaces with a germicidal wipe. Now I want you to take a look at these pictures pretty carefully. These wipes have dry time to them, and that dry time is very important. So if you notice, this says the 3-minute germicidal wipe, and that means that after you wipe something down with this wipe, you have to wait 3 minutes before you can put anything on that horizontal surface, before you can, consider it clean. All right, this germicidal wipe works within 3 minutes. If you're already wiping down or you're already placing stuff on there after 30 seconds, it's not really considered clean. And every one of these germicidal wipes has a dry time. Some of them are 5 minutes, some of them are 3 minutes. I've seen more than that. So really pay attention to that's really, really important, is this dry time. Okay, so once you wipe something down, I know 3 minutes can seem like a long time when you're turning over rooms, but wipe it down and then do something else. Do whatever else you need to do in that room to prepare for the next case. Let that dry for the allotted amount of time that it says on the manufacturer's instructions. Okay.
And Lori, may I interject really fast? And
course.
that's one of the reasons we love wipes, because a lot of the wipes are a 3-minute dry time or kill time, as I like to say. But in the older times, we would use a lot of spray disinfectants, and they're very wet, very, very wet. So we just need to, if you are going to use a spray, making sure that people understand, getting everything everywhere, but you have to let it dry on its own. And if you start wiping it dry, you're taking away what it's doing.
Exactly.
The other thing is sometimes you will have disinfectants that are a lot less expensive, but like you said, they may have a 10-minute kill time, and we just, you can't afford that time on a turnover of a room. So just be aware of that.
This was, if I can interject really quickly, this was another big one with COVID, with not knowing which cleaning agents originally, if we could think back 2-ish years, there was some question about what we needed to surface clean due to COVID, how long the virus lived on surfaces of varying types. And one of the other things we saw was, again, people being really quick to wipe, whether they were spraying down, and some countries were requiring fogging of the OR, kind of every day, which could have led to respiratory issues. All of that being said, it's just important to know what the agent you're using. If there's an emergent need, is there a different agent that you're using than you normally are? So again, you're disrupting your routine and going from 3 minutes to 7 minutes to 10 minutes, and just being always aware of the purpose of your cleaning. If there's an emergent need, what that has changed in your life, and being aware of that, because you can't just go, I'm going to use one of Dr. Goldstein's favorite words, rote. You can't just do it based on a rote kind of routine. You have to put some thought and some conscious decisions into it, because our environment does change and our circumstances do change, and that can lead to a lot of infections if you're not aware.
I'm going to give everybody a quick tip for education purposes, and Tom we can always quote the Quad A standards, but the best practice is always to know what that cloth is effective against. Some are not fungicidal. Some actually haven't been shown not to be effective against COVID. So on the Quad A accreditation side, we look when we go into a facility that people know. But what I've educated our staff to do is to look at that drying time and actually take a Sharpie and put a big, either 3, in this case it would be a 3, over that container, so that everybody knows when they pick up that container that that's a 3-minute drying time. When we've gone to facilities as a surveyor, we've seen 3, 4, or 5 different wipes that have different drying times that the staff is unaware.
Yeah, that's a great piece of advice. I like that, to write on the Sharpie, how many minutes it's good for. That's wonderful. I never thought of doing that.
And Lori, one other thing we saw during COVID is when these were in short supply, people were utilizing, I know in the US, I saw many times clinics and such were using the household cleaners.
Yeah.
And unfortunately, those are great for your kitchen surfaces, but not necessarily, they're not hospital grade or healthcare grade.
Right.
So just being aware, I mean, you know, they were just desperate, and I understand that, but in our operating theaters, we have to use healthcare.
Yeah. And you can
grade.
see here on this list, look at all those, you know, that kills bacteria listed, and you can see all of them there. So, so important. And make sure you're getting all your horizontal surfaces, your back table, your Mayo stand, your OR chair, and again, your anesthesia equipment. All right, that blood pressure cuff, that pulse ox that's being used, probably patient to patient to patient. So make sure that we're really cleaning our anesthesia equipment well. Okay, don't forget that.
And please also, on all of the cords, when you clean them, put them up, you know, so they're not on the floor. We see that kind of regularly, and we want to make sure that there's a process that when they've been cleaned, how do I walk into that room and know that everything's clean? We like to tell people, if you have a hook to put it on or something, that's
simple plastic hook.
It's been cleaned, it's ready for the next patient.
Exactly. And every facility I know I've seen as well, they have their own protocol for showing that it's ready for the next patient. So they hang it a certain way, or they do something to show it's been cleaned and it's ready for the next patient. So whatever you want for your protocol, there's no right or wrong answer. It's however you want to do it, and then just train your staff to know and understand that, yep, this has been cleaned and it's all set for the next patient. Don't forget to look down. Don't forget those you know, wheels and casters and the Mayo stand. All right, make sure we're cleaning your microscopes, your sinks, your countertops. All right, make sure, I always tell people, look up and look down for sure. If you've got vents in your operating theater, don't forget those vents. They get so dusty. Those vents get so dusty. Make sure you're cleaning those vents, and, you know, pull things out. Pull out at the end of the day. Make sure you're pulling out your furniture. Pull out those, you know, those anesthesia carts, and get them away from the wall, and make sure that, you know, you'd be surprised what wet cells and what things can accumulate behind some of these pieces of furniture. So make sure that you're pulling things out and you're cleaning well.
Yeah, dust bunnies, and like you said, up at the top, looking at those vents, because we see that pretty regularly. Also, ceiling tiles, sometimes they'll start to crumble a little bit. They get dry, and so just what you're saying, look down, also look up.
Also look up, and you'll appreciate this as a surveyor. I know for years, and with good intentions, oxygen tubing used to be put across the ceiling and then come down so that you wouldn't, you know, hazards and trips and like that. But how do you clean it? Those things are going to collect dust. So how do you get up there and clean that oxygen tubing that's up there? You're going to have an inch of dust up there. So just be really careful to look up. Going into receiving and storage, this is really important in infection control. All right, you want to prevent outside contaminants coming into your operative area. Okay, no corrugated boxes. And I put this little guy on here because this is something that I've actually seen myself. This is a silverfish, and I was opening boxes, and it was a box of just, you know, equipment and supplies to bring into the operating room. And I'm not in the operating room. I'm opening it out, you know, in the supply area, and lo and behold, these little guys were on the bottom of the box. So they're there. It happens. Those little guys can make their way into these corrugated boxes. They're coming from who knows where. Debris, dirt, insects, they can all gather in these corrugated boxes. Do not bring cardboard boxes into your operating theater. Tom?
Yeah, sorry. So this is one that I love, just as a good example, because some people listening here may be in an area where there are a lot of invasive species, and then some people who are listening to this may be in an area where they don't get a lot of insect life and bug life in general. And I remember actually being in a clinic in the UK, and we were talking about this very issue, and the center said, well, we don't have a lot of kind of, you know, I don't know what exotic bugs are, but they said, we don't have a lot of exotic bugs or things like that here. And I said, okay, I understand that, but what region of the world did this box originate, right? So not only are you talking about potentially bugs that you're not familiar with, but you're talking about transplanting bugs and invasive species from elsewhere in the world, no matter where you are. Right. So with the global supply chain, you have things coming from, you know, Europe to Southeast Asia and vice versa. And so no matter what might have laid eggs inside that box, it's probably not native to where you are. So for those who may be listening to this thinking, well, that's not really an issue for me, that box came from somewhere else. And it may be an issue where that box came from, where it was shipped through, or just the planes it was on. So,
or the truck that it was
the
loaded
truck
on.
that it's been sitting on. Yes,
exactly.
the truck. How long has it been sitting on that truck? Yeah.
Yes. So I think this is something that some folks in some areas of the world may tune out because it may not seem like a local issue for them, but basically this is a local issue everywhere.
Yeah. And Lori, this is a personal picture of mine. We see this so commonly, and people, they're just in a rush. They're trying so hard, and most people have an issue with storage, but we always just say, whatever you can do, just get it out of those containers, put it in a clean container that you have control over, and if you have a clear container, that's even better, but get it off of the floor. That's quite important as well.
Yes, absolutely. Check your sterile packs. Okay, all your sterile packs that you have sitting in your storage closets. Make sure that those packs, check for evidence of damage, holes, moisture, things like that that could get in there if it's been compromised, and if sterility has been compromised, if there's a tear or something in there. And you want to make sure you're storing items according to manufacturer's instructions. So check those IFUs. It's going to tell you exactly the environment that it wants you to store this this piece of equipment, this type of supply in. So clean, dry continues, as Dianne said, off the floor, away from things that could have potential damage. Try not to overstack things on top of each other, especially sterile packs, because then you can certainly compromise the sterility when you're starting to pile things up on top of each other, definitely keeping things off the floor. So these are just things to keep in mind. Not reusing single-use items. We did go through this. Ensure that all your fluids, your supplies, check your expiration dates. So I know some facilities, they have in their policy to check expiration dates, let's say monthly. The beginning of every month or the end of every month, they go through their cabinets, they have a little checklist, and they have all of their items and all of their supplies, and they go through and they check off, this is within date, this is within date, just making sure that those items way in the back of that cabinet that you don't see every day, that's been sitting there and something we haven't used in months, you got to pull those out and make sure that they're all within date. There's a use by date, and then there's a date that it was manufactured, so to make sure that you're looking at the correct date. But you want to document it, have some type of monthly log or something that you have, and you can assign it to each person in the operating theater. The pre-op and recovery room is so important. A lot of times you're storing things in there. Anesthesia as well. Don't forget our anesthesia department. They've got their crash cots. They have all their meds in there. And you want to just continually be checking for expiration dates and checking off and making sure everything is within date.
And Lori, I think it's also very important that this little 2 with a slash in it, it's quite important to show people this, and also on those new hires, making sure that they understand the messaging that's on the packaging, so at the bottom, the use by date, the date of manufacture. I've actually seen people see the date of manufacture thinking that's the expiration date and throwing away, things, and that's so costly. So having in that orientation of new hires, helping them understand what to look for. And of course, obviously, I love what you said about having a little log where someone has a process, and we see that process and it's assigned to someone. They can delegate it out, but someone has responsibility to do that so that we're turning over our stock. We also really, just another aside, is having with our inventory, our first in and first out, making sure that our inventory is rotated so that you don't have something way in the back that's expired, because that costs you money, and our resources are so important in the organization.
Check your refrigerators. Everyone always forgets the refrigerators. These are things that are in there, your viscoelastics that have to be, refrigerated, your visco, things like that. Make sure you're checking your refrigerators as well. Keep that log on. You could keep it on your refrigerator, just making sure that you're checking your refrigerator for outdates as well. So catch all of those different areas of your operating area.
And on that note, the refrigerator, we need to look at the temperatures of the refrigerator and making sure that everything in there is being stored according to the manufacturer, and that we have a process to see over the weekend if the refrigerator breaks down, do we know that everything was maintained, or if the electricity went off? That happens. So how do we know what happened? And we also have to have a protocol that if it does exceed the temperature because the electricity went down, what do we do with those medications? Do we call the manufacturer and say, hey, it was, we believe our temperature or the power was off for 24 hours. Do we need to discard this and replace it, or is it still good?
Yeah, so, and one thing we see on surveys a lot, especially in the anesthesia world, but also in the surgical world as well, is single-use items that have been opened and not used, and then either put back in stock or reprocessed in some way, with a rationale saying, well, it says not to use twice, but it doesn't really say what to do with it if it's opened and not used. So it's very important to understand that once it says no to, even if you open it, if it's been exposed to anything, that is no longer usable as a sterile item in surgery or anywhere else in your facility. So it has to be discarded.
Nice thing you can do as well, if you're looking at manufacturer's instructions for how to store things in the fridge. What we have done in the past is we've taken a look at the items that do get stored in the fridge. We have a little supply list, and then next to each one, what the temperature, what is saying that the temperature that it's supposed to be kept at, and we actually keep it on the refrigerator. So in this fridge, we have, you know, this coat, this, that, so on and so forth, and next to it has to be stored at this. So whoever's going in there knows that, you know, each item and what the manufacturer is saying it needs to be stored at as far as the proper temperature. And it just gives them a little indication, so they know every time they go to it that, you know, they understand that it's been stored in the correct place. I mean, some people have only 4 or 5 things that they keep in the fridge. You got 4 or 5 things written on a piece of paper, put down what their temperature requirements are, and you can put it on the refrigerator. Hot topic, always, decontamination of instruments. I know this is always something that everyone is eager to learn. Talk a little bit about decontaminating your instruments and how we can prevent infection. Remember that decontaminating instruments begins immediately at the point of use. This can be on your back table, okay? That your instrument wipes you have back there. Just make sure that you're preventing things from getting debris and things that can cake on your instruments. I know it's ophthalmology. Everybody always thinks, oh, this is eyes. We don't have, you know, we don't have a lot of debris or bloodborne pathogens or blood and things like that. Well, there are cases that we do, but still, even though you can't see it, doesn't mean it's not there. Transport it in a closed, puncture-proof container marked biohazard. Make sure you're decontaminating all your instruments, okay? Not just the ones that you use. I can't believe I still see to this day, people separate their instruments that come out of the operating rooms, and they tell those in sterile processing, well, these were used, these weren't, because somehow they think that, you know, only those instruments that were used are going to get washed and decontaminated. If it's opened on that table,
with our hands,
right? If it's opened on that table, if you're opening it on that back table, it is on your back table, used or not, it is getting washed with everything else. Okay? It doesn't matter if it was used. If it's on your back table, it gets decontaminated. Okay. Using critical water, all critical water is treated water. It's just a fancy term for it. Sterile or distilled or some type of filtered water. Just making sure that that last rinse of your instruments is with treated water. Okay. Multi-part instruments get disassembled. Jaws and hinged instruments are opened. You want to be sure you're flushing your lumens and you're visually inspecting your instruments. And I have some, just some thoughts here. So this is, say, an IA tip you see on the top left, multi-part instruments. Something to remember. If it didn't come to you that way, it doesn't get sterilized that way. In other words, these instruments come apart. Right? They're not fused together. Those tips, even it comes apart even one more piece. That back piece actually can come apart as well. These particular instruments are in 3 pieces. That's how it was purchased. That's how it came to you. That's how it gets washed and sterilized. Okay, you do not keep it, even though you put it together for surgery, it comes apart to disassemble and to decontaminate. Very, very important. They're not meant to be decontaminated and sterilized together like that. Okay, they have to be taken apart, especially because you got to get that steam, you got to get that sterilant in all those little crevices.
All surfaces.
All
absolutely.
surfaces. Flushing your lumens, making sure you're flushing your lumens. Okay, viscoelastic. Okay, this is big, and we're going to talk about TASS, but viscoelastic gets stuck in there. Lens fragments can get stuck in there. Making sure that you're flushing out your lumens. It can be with a machine. There are machines out there that can do it. It can be with a syringe, copious amounts of water. Just make sure after you're flushing that you follow it with air. Don't let fluid accumulate in these lumens, because what's going to happen is those fluids going to stay in there. Those nucleus pieces can stay in there. It gets thrown in the sterilizer. The next person, the next patient, it's going to get pushed out into someone else's eye. That's how we get infections. So make sure that you're flushing your lumens. All those instruments, you see the jaws, your hinged instruments, we got to open them. Make sure those jaws aren't stuck together. Open them up. Let that sterilant, let that steam get to all those surfaces. And then transport in a closed puncture-proof container. It doesn't have to be complex, and you don't have to spend a lot of money on it. These are simple items that you could use. I mean, one of them literally is just a regular bin that has a cover. It has a biohazard symbol on it. It keeps everyone protected. You can buy one like the one on the left from an instrument manufacturing company. Whatever you have to use, just make sure that it's closed and that you have a biohazard so everyone knows what's in there is dirty. Visually inspect all your instruments. I always tell everybody, you wouldn't want a family member coming in and that instrument on the left is being used on them. That is rust. Okay, that is not sterile. I hear it so often, Dianne, I'm sure you've heard it, is, oh, well, it's gone to the sterilizer, so it's sterile. So think about it. So all that rust, what that's doing is preventing your sterilizing agent, which is typically steam, from actually making contact to that instrument. Okay, that's prohibiting. It's not sterile. That is prohibiting, you know, the sterilant reaching that instrument. Look at that debris. If you look inside the handle, that's a great picture, Dianne.
Yeah,
if you look inside the
I see this.
handles,
I mean,
yeah,
you know,
yeah.
a lot of times I'll ask people, is it okay if I see something and it looks a little strange? I'm like, may I just go ahead and open this pill pouch? And I open it, and you know, I let them see this. I was like, would you, just like you said, would you want this utilized on your mom's surgery or your child's surgery? And of course they go, no. But I think the visual inspection gets lost. People are just, you know, they're cleaning, they're cleaning. They are in a rush. Everyone's in a rush, but that's, you know, that's part of it. That's one of the steps that needs to be taken, you know, and also we need to make sure while we're doing that, we're inspecting, or is the instrument in good repair? Or do we need to send it out? Do we need to have things sharpened or reapproximated? You know, so that is a step that gets lost in a rush, but we need to slow down just a tiny bit, or at the end of the day.
Yeah, I would not want to give a surgeon that instrument. I would never want to give a surgeon that instrument. Never, you know, that's why it's so important to be opening things. I'll give you a little hint. If you do get things like that, just simple rust, that can be repaired. That can be, you know, that can be repaired. And one of the things that takes that rust is a pencil eraser. It works incredible.
Good.
Yes, yes, it does. Pencil eraser works wonderful for rust. Get those hinges apart, and you can actually use a pencil eraser and really get that rust out.
Learn something new every day. That's fabulous. That's fabulous.
So just a little hint for that.
Hey, may I add one more thing? As you're visually inspecting, we see this sometimes in office-based settings that instruments that are disposable instruments sometimes get into pill pouches or into packs. We need to make sure that we're utilizing instruments that can be reprocessed. You know, if you're seeing things that don't have the manufacturer's stamp on there, you may want to investigate and see if it's something that really should have been discarded.
Very true. Absolutely. Reprocessing items that are not meant to be reprocessed, and that's how we run into trouble. So. Lawrence, I got a couple of more poll questions if you'd like to throw those up for us. So I'd like to know from those of you watching if you use immediate use sterilization, okay, which is flash sterilization at your facility regularly. I don't mean those once in a while, every now and then. Who out there uses flash sterilization in your facility regularly? Okay, all right, so that's very good to know. All right, that helps. And then I think we have another question, Lawrence. Something I'd like to know, because I do see this quite often when I give these talks, is do you use biological indicators? These are spore testing. I do know that most facilities do use indicator strips, but I'd like to know if you do biological indicators, if you're actually doing what we call bug testing. So monitoring your sterilization process. Okay, this is an actual spore testing. So, okay, so good. I'm glad to see that we do have quite a few people using spore testing, because I do see very often that it is not used and that we're just utilizing indicator strips. So I am very happy to see that. So let's go into sterile processing. So really important is that you're using the correct settings for that sterilizer. This is not an area where it's one size fits all, okay? This is where your instructions for use come really important, come in handy. Okay, compatibility. Let's make sure that your temperature, duration, everything, the instruments and the instrument cases are compatible. I'll give you a quick example of what I mean is that, and I've seen this happen, is that you have let's say a rigid container. You're using the rigid containers to sterilize your instruments in. and you had an instrument hit the floor. Let's say it's one of those situations where immediate use sterilization is appropriate and would come in handy. And you clean that instrument, you needed it right away, you popped it in one of your rigid containers, and you put it in for that flash cycle, which is typically what is called a gravity displacement cycle. It's a very quick 3-minute cycle. You sterilize that instrument, you put your indicator strips in there, and you're done. It comes out, you open it up, and that indicator strip did not change. Those instruments were not sterilized. That's because that rigid container is not validated for gravity displacement. It can only be used in pre-vacuum settings. So you have to take a look at your manufacturer instructions for both your instruments and your trays, everything, and make sure they're all compatible. Because steam did not penetrate because it's not meant for that type of setting. So that's just an example. And then you got your validation. So you have your chemical indicators. There are different types. Okay, doesn't mean one is better than the other. It's just what's more appropriate. There's type 1 through 6. Type 5 or 6 is typically what we want to see used in healthcare settings. And then you have your biological indicators, and you can do those really, if you're using biological indicators, your blood testing at a minimum weekly. You have to think, how can I go back if I had a problem? Let's say we did have some type of infection. How can I go back and make sure that, you know, my sterilizers were working properly? So at least a minimum of weekly. Best case scenario would be daily, but I do know that those type of equipment can be expensive. If you're doing biological, the incubators can be a little bit of money, but you know, something you want to see at least done weekly. Dr. Goldstein?
Yeah, so Lori, that's a great point. At Quad, it is one of the requirements of accreditation that you do the biological testing at least weekly. And one thing I just wanted to add to this is you're required to have a log of your sterilization processes. And that log needs to contain all the parameters that were used, but also the instrument sets that were used. And for your facility, should there be a problem or an infection, you really want to be able to identify where that breach occurred. And without a proper log, identifying what actually was sterilized, either that be by number or how the sets are named, there's no way to be able to know that and protect your patients.
That's right, because you need to be able to track those patients,
right?
You know, so that log allows you to go back and see which cases were performed on Tuesday and Wednesday, and be able to track and just, you know, look for things and notify patients if you need to.
Exactly, and most sterilizers have printouts that will come up. And you can also be able to go back. You can put it in their medical record, however you want to track it. You could just have a simple log, but make sure that you're tracking also the load. So each sterilizer will have a load number. Some of them are simple. It's the date and then 01, 02, 03. But you know, make sure you're doing those tracking so that if you do have a problem, you can go back and make sure everything should be able to match up. So your number of the load number that you have for your sterilizer matches what was given to the patient, matches, okay, I looked and that day you can go back to your log and see that the biological indicator was negative. Everything should be able to match up. So really being able to track is it's a key to, you know, not so much infection prevention, but be able to go back and look. If you did have a problem, you did have an infection, to be able to identify possibly when you're doing.
Lori, oh, I'm so sorry.
No, please.
No. I apologize. But if you have multiple autoclaves, that's really important as well. In some places there are two. So we need to identify on pill pouches, you know, or on packs, or, you know,
sterilize A, sterilize B, however you want to do it. There's no right or wrong. But however you want to label it. But if you do have multiple sterilizers, very important is that you're putting down not only that load number, what sterilizer it came out of. Yes. And then you're keeping
just tracking. That's the thing, being able to identify and track. That's quite important.
Exactly. So procedures for processing ophthalmic instruments, they can differ from those of general surgery instruments. So if you're a multi surgical facility where you're doing other cases besides ophthalmology, please be sure you're separating these instruments, cleaning intraocular instruments from general surgical instruments. It can help that cross-contamination from that bioburden from really heavily soiled instruments that you can get in regular general surgery, okay? Because most instance of TASS, toxic anterior segment system, can be related to instrument processing. So let's make sure that we're really taking good care of these ophthalmic instruments. We're not cross-contaminating them with things that can happen in general surgery where you get those really heavily soiled non-ophthalmic instruments. So guidelines for decontaminating instruments. We talked a little bit about this. Immediately after use or even during the procedure, okay, you want to wipe those instruments down. Sterile water, sterile lint-free sponge or cloth, flushing, immersing your lumens in sterile water. Make sure you're using the IFUs, cleaning your intraocular instruments in a designated cleaning area separately. Okay, use those single-use disposable cannulas when you can. Or I know they can be expensive, and that's okay. If you can't use the disposable ones, you can use the reprocessing ones, as long as you're reprocessing them according to the instructions for use, and you're taking the time that you need to flush these instruments and to rinse these instruments as well. At the close of the procedure, use critical water. That's that filtered, sterile, treated water to flush your phaco hand pieces, any of your irrigation, aspiration ports, any of your cannulas, your Simcoes, reusable tips, anything like that. You want to be sure that you're flushing with copious amounts of fluid. I know typically in the past, I've seen 120 cc's. If you're using a machine, most machines actually do flush with 120 cc's of fluid, followed by air. If you don't have that, at least get that good syringe and get, copious amount of fluid to get through there, and make sure you're following with air. Don't leave your fluid inside these lumens, okay? After your cleaning, you have that final rinse, okay, including those lumens with critical or sterile water. You want to use that air. If you're using an ultrasonic cleaner, all right, making sure that you're cleaning that ultrasonic cleaner, you're changing the water. Typically, you're changing the water out after every use. IFUs will tell you, but we want to make sure we're changing that water out, okay? We're disinfecting, we're rinsing, and we're cleaning that ultrasonic cleaning according to the manufacturer's instructions, all right? Make sure you're using whatever supply is telling you to. Don't put anything in your ultrasonic cleaners that don't belong there, because then you're going to have problems, and that's where you're going to have your infections if you're using cleaners that don't belong inside that ultrasonic cleaner. So make sure you're using the correct cleaners, okay? If it's not contraindicated by the manufacturer's written instructions, 70 to 90% alcohol, and dry it with a lint-free brush. Lint-free cloth is usually acceptable. And just make sure we're really looking at our instruments afterwards. Those magnifying glasses are wonderful. Okay, these are small little micro instruments, and we want to make sure that we're taking a peek and looking at them and making sure that they're in good condition. All right, it's that dirty word. It's TASS, toxic anterior segment syndrome. It's that acute severe intraocular inflammation in the anterior segment that can happen after intraocular surgery. It can usually present within 12 to 24 hours after surgery. Different from an endophthalmitis, which can often happen 2 to 7 days after surgery. So we kind of want to make sure we understand the distinction there. So we have quite a few things that can cause TASS, right? Contaminated BSS, irrigating solutions that have abnormal pHs to them, viscoelastic agents, topical ointments, all of these things can cause TASS. Typically, what we see with TASS is inadequate flushing of instruments in between cases that result in that buildup of viscoelastic solution inside those cannulas, that buildup of foreign material that stays in there during the sterilization process and then used on another patient. So, COVID-19. Diane, I think I'm going to have you do this particular slide, because I think you will do a wonderful job at really talking about COVID-19, this COVID-19 area, and this. Yeah, please.
Well, thank you. It was such, we've learned so much in the last 2 years, and I just really want to thank all of the communities, that we're speaking with today, because it was hard and it was a burden on staff, but we did it and we're doing a great job. One of the things that we just have learned from this is that training is important. We need to help people understand with not only COVID-19, but any type of emerging infectious disease, that we're getting out in front of our staff and we're talking about the newest information in the most timely manner. So we're going to train the staff about new symptoms and how we're going to mitigate the disease transfer. So, like we said, training, signage, however we can to push the information, emails, posters. I mean, just, even in the break room, we want to put information right in front of people. Visual cues are very, very important. But then, what we learned also is if we have new equipment, we have to monitor and make sure that we have a good inventory of supplies. We saw PPE being so sparse, when we needed it. But it was kind of interesting because before COVID, I think when we looked at inventory, we kept a lean inventory all the time. So what we need to think about now is, do we need to keep a 2 to 4 week supply of inventory if we can for masks and gloves, but also rotate that so that we don't have N95s way in the back and the little elastics, when we go to put them on that they pop. So we want to keep rotating that inventory to be able to safely provide care to, to our patients, but also to protect ourselves. That's quite important. So one of the things we want to make sure that we're doing, and I think hopefully that this is going to continue beyond COVID-19, is that when patients come into our facilities, we're going to talk with them, or do you have a fever? Have you been feeling unwell? If you are, we need to stop. We need to say, perhaps today's not the best day to bring you into facility because you're not at your best. So we're going to start that on the phone, maybe the day before, as we call a patient and talk with them. Just say, if you're not feeling well in the next morning when you're coming, give us a call before you come in. We're also putting signage at the front door of the facility to say, if you're coughing or you feel feverish this morning, why don't you give us a call before or knock on the door and we'll come meet you outside to kind of do some infection surveillance.
The days of coming in sick are long gone.
No, yeah, that's
that
really
ship has
gone.
sailed.
That ship has definitely sailed. But that reinforcing of the culture too with our own staff is, if you don't feel well in the morning, it's just not worth it anymore.
No.
We'll work a little bit harder today so that you can stay home and come back. So whether it's COVID-19 or the flu, whatever it is, just stay home. But also that enhancing the disinfection of the environment. We used to, I think, sometimes just take it for granted. We'd wipe down here and there, but now we're going to the doorknobs on the hour, or when COVID-19 was really at its height, we were doing it between every patient. But making sure restrooms and waiting rooms that we're disinfecting them more frequently, for couches and things that are in the waiting room that can't be wiped down, that we have a spray disinfectant that we're using. But that's really important. It was like our environmental disinfection on steroids. We need to keep doing that. Yeah, but our infection control coordinator and the medical director and members of the team, we really want to monitor our Department of Health and regional departments of health, if your state or your country or your region, to see, because a lot of times in our community, we're seeing enhanced transmission of infectious diseases. I know it was kind of, I was remembering back to the old days when we would get a fax from our Department of Health that would say, we've got this in the community. In Texas, we had an outbreak of measles a couple of years ago, and we were getting that via fax. Now we get it via email, and sometimes we get it via text. But someone that's looking at this and going to whatever your leadership is and saying, hey, this is upticking. What do we want to do? Because with COVID-19, we were testing our patients before surgery. Now we've abandoned that. But our decision is that if we see it rise up in the community transmission increases, then we're going to go back and start testing again. So that's really important. And then also just flexing our protocols, whatever we need to do. Sometimes, we were just doing, we're now just kind of asking people what, we see that a lot. What are your symptoms? But maybe we need to go back to temperature checks. Whatever you need to do, just communicate with the leadership and decide what's appropriate.
And updating those policies, because how many times you go in a facility and you look at these policies and think, how old is this, right? It's 20 years old. You have to look at these policies, signing off on these policies, update them, keep them up to date. Dr.
Right,
Goldstein,
that leadership.
I did, because I found it very interesting in our world, in the accreditation world, and the ophthalmologists and the ophthalmology world. The ophthalmology staff were the canaries in the coal mine when it came to COVID-19. In many of the facilities that we surveyed, we noticed that it was the ophthalmologist or the retinal specialist who were the first to come down with COVID-19 in the beginning of this, because they were really so close to the patient, face on face to the patient. And really, we saw the greatest effect where adherence to the appropriate policies and personal protective equipment, which is PPE, made a huge difference. And once we paid attention to these protocols, there was very low transmission in the facilities that we accredited.
Excellent. Very good. Oh, we're getting into our 1 hour mark, so I appreciate everybody sticking with us because we have so much wonderful information to share with you. We talked about our signs, Dianne. These are all the signs that you had mentioned, putting around your facility, and reading the following, stating whether any of these apply to you. Bring in your staff. Do this as a team approach. But look at all these great signs. Just things that you can have around that just remind us of all the things that we should be doing. Social distancing. Face masks required. All right, we're going to go into a little bit of a panel discussion. Tom, do you want to?
Yeah, just two quick things. One, on the previous slide, I know we're 2+ years into COVID, so sometimes when we're talking about COVID, I think people can kind of say, yeah, we figured out how we want to handle that. But I think the important takeaway from everything we're talking about with COVID is planning. Establishing a plan gives you a point at which to divert when the next thing arises. The next thing is not going to be COVID-19. It's going to be some variant of some other zoological disease that jumps to humans, right? Or there's going to be a respiratory infection of some sort. There's going to be some other infectious communicable disease that requires something that is a deviation from what we did for COVID. And so the takeaway here isn't that you have to do exactly this. It's that these are all of the things that we put in place for COVID that provide a great starting point for the next. That as it evolves, as it adjusts, as the next thing comes up, you will have these tools and resources at your hands to then shift. And I think with the last talk that Dr. Goldstein and I did about a year and a half ago, we shared, Quad ASF came up with a 59, 60-page resource guide for COVID, both in English and Spanish. Sorry, those were the only two languages we were able to get it in so far. But they had the signage from World Health Organization and CDC. It had scripts for your staff to be reviewing with patients beforehand. It had processes and policies and logs, and all of these things are great. And if you haven't used them, I think the CyberSites website has them. Our website has them. But again, these are great to keep in your storage for the next time you need these resources, because you can adjust them and you're not starting from the beginning, because obviously the next thing is going to require some variation. The other point that I wanted to bring up, and I'll try to keep it short, is someone asked in the chat about staff strength and being so important to infection control, and it dovetailed nicely with a point that I wanted to make, and it's this: everything we talked about here today is even more important in a transient environment. So if you are in a developing country or an underdeveloped country where perhaps the level of training for nurses or for other techs or non-clinical staff isn't as robust as it might be in other parts of the world, all of the communication, all of the training, all of the signage and the tools that we're talking about become that much more important, because you have to raise the level of expectation and almost do that educational component within your center. And so if you're working with, nurses or techs or assistants that may not have had such a robust training environment as they might have in other countries, then it becomes incumbent upon the leadership of the facility to make sure they have resources like the ones at CyberSite, like online learning modules and others. And it's not only important in developing countries and underdeveloped countries. If you're in an environment where you're bringing in staff from around the world, even if their training is robust, it's different than another staff member's training. We do a lot of work in the Middle East, in UAE, and in UAE, a lot of the population comes from 5 or 6 or 7 different countries. And so if your staff is trained if you have 7 staff members who are each trained in a different learning environment in 7 different countries, the expectations of each person as to their role and as to their duties and as to where the handoffs from one function to another function go may be different. So pulling your staff together and having very clear communication about the expectations and roles of each person and each job description is super important, because a nurse trained in the Philippines may think something very different than a nurse trained in Pakistan, than a nurse trained in China. So if you have nurses from the Philippines, China, and Pakistan on your staff, you just want to make sure you're all having the same conversation about what the duties entail, because they may have different expectations, and you want to be really clear with that.
That's a great point.
That is
I mean,
a very
that
good
is really a good point. We don't think about that all the time in the US, you know, but you're right. It's we need to make sure. And I think that's why those protocols, visual signage, reminding people so that these things become muscle memory. You know, if it's in your face constantly, it becomes muscle memory. That's great. That's a great point.
It was excellent. Thank you, Tom. We had some great questions that came in. I know we still have some time. We're going to go through each question. Each one of our panelists is just going to, you know, kind of take one and go into it in detail. So one of them was, how can infection cause eye damage? What are the major things that we have? And I think Dr. Goldstein, would you be able to provide us with an overview of some of the damage that infection can cause in your eye?
So I really want to get back to the basic on this one, because it's all about endophthalmitis. As an anesthesiologist, I've witnessed thousands upon thousands of eye surgeries over the years, and that's always been the dreaded complication that we worry about. And I think the way endophthalmitis causes damage is the inflammation and infection inside of the eye. You know, the eye is a pretty, you know, the inside of the eye, really, there's not a lot of infection fighting capabilities, you know, inside the eye. So any introduction of any kind of pathogen can cause severe damage very quickly. And I wanted to comment on one of your slides, because the difference between TASS and endophthalmitis is something that we really need to be aware of. You know, a little later on, we talk about eye pain being one of the first features of endophthalmitis, and it all goes to education of our patients to make them be able to report back to us when they're feeling symptoms or that really reflect upon whether they have endophthalmitis or not. So that's how it causes damage. It causes damage to the vitreous and also causes damage to the retina, and unless treated effectively very quickly, can and will lead to blindness. So in that sense, it's essential that we take care of it very quickly.
So how long can an autoclave box remain sterile? I thought this was a really good question. I don't know if, Tom, did you want to take a stab at this, or Dianne?
Sure. So the quickest and the least satisfying answer in history is it depends, right? That's true. So there's a lot of factors that impact how long a box can stay sterile. Some of it being the packaging and all. The easiest thing is to always look at the manufacturer's guidelines, right? So whether it's boxes, wrapping, containers, peel apart packaging, all of that is going to have its own manufacturer's guidelines, and some of them may have time related, and some may be event related. And so some small studies have shown items remaining sterile for 12 to 24 months, but this is all presuming that you don't have a packaging that says that it remains good for 3 months, 6 months, whatever that is. But it's also presuming the environment and the processes are good. And that's really, I think, the biggest takeaway here. You can pay attention to the manufacturer's guidelines very easily. And as you're bringing in supplies, especially with the supply chain issues, again, being aware of the new packs that you might have to bring in because your manufacturer is out, or whatever the case may be, is super important. But equally important is auditing your process on an ongoing basis. If the temperature doesn't stay right in your storage, if the humidity doesn't stay right in your storage, if things are overpacked so that you're opening a drawer with sterile supplies in it and they're overpacked, and all of a sudden they become snagged, all of this would impact the sterility and violate sort of any time periods that are there. So, you know, these audits of the process and the policy are super important. I can tell you I have some pictures that I keep in a different presentation where the autoclave is on the shelf, and above the shelf in cabinetry are all the sterile packs. So as soon as the autoclave vents, all the steam goes directly up into the packs. So none of those packs are sterile. So the packaging might say it's good for a year, but none of them are good because the process and the storage capacity was wrong. So
event
that's
related.
the unsatisfying answer that I can
Thank you. Dianne, let's talk a little bit about needlestick injuries.
Well, one of the things that we just really want to do is have your staff evaluate if you have mechanical devices, mechanical safety devices that you can utilize with syringes or IV catheters. That's, kind of the best practice. If you don't have that, if you're utilizing, just direct syringes or IV catheters that don't have mechanical caps, you want to just be very aware. You want to use a scooping method after you have a needle that's exposed, telling what we used to do 20 years ago. It's horrifying, but we used to stick things in mattresses or foam or whatever.
Oh, yeah.
We don't want to do any of those things anymore. It's very important that if we can't properly scoop a needle, we put it in a neutral area. And then we use kind of that pin scooping method that we used to, or a box scooping method. And if you're on a sterile field, just communicating that you've got suture material and putting things to a neutral space. I think that's quite important.
Awesome, thank you. How to prevent infection within 48 hours. So Dr. Goldstein, give us some ideas.
So that's a great question. And, I pondered over this one for a bit. And I think the best answer to this is go back to the basics. So preventing infection for the first 48 hours starts when the patients are booked or scheduled to have surgery. So it's all about education for them, making sure that they've performed all the proper instructions, whether that be preoperative eye drops, antibiotics before surgery. And when a patient arrives, one of the things we notice throughout the world in our accreditation is there can be language difficulties and interpretation difficulties. And CyberSight and Orbis obviously are experts in trying to bridge those gaps. But the key is to have the patient and the staff understand what needs to be done and that instructions can be followed both before, during, and after surgery. Obviously, attention to detail is the key. And this presentation has given a lot of it, and there's a lot more out there. And I really do believe in the KISS principle, which is keep it simple, stupid. We have already, illuminated everybody about basic infection control practices. And the other thing I just want to point out, which is a requirement of accreditation, is that there be active surveillance for infections postoperatively. So there's no good way to prevent infections unless you know that you actually have them and that you have a problem. So that's key in the first 48 hours as well.
Oh, and Dr. Goldstein, I'd just like to add, I love what you said about, tracking your infections. It's also quite important that your leadership, if they become aware of infections, that they sit down and they look at, kind of looking at the risk. What are we seeing? What's the trend? If we have a trend, let's get together and talk about it. What can we interject? Do we need better post-op instructions for family members? Do we know that we have an infection that's coming out of OR1 versus OR2, but really doing some performance improvement studies, looking, doing some corrective action, and just making sure that if we have a trend with a surgical site infection, that we can address that properly. But I love what you said about patient education, because that's really quite important, making sure that they're not going to be in a bath or, rubbing their eyes or things like that. And also that their caregiver has good instructions and acknowledges that they understand the instructions.
Very simple items like having patients understand, or their caregivers who are giving their post-operative drops, that they need to wash their hands.
Washing the hands, yeah.
And most people don't understand that. So that is essential. And I think if these pieces don't all come together, then surgery needs to be delayed until we can communicate effectively.
Agree. So in an outreach setting, when there's no operating theater to work in, how do you ensure proper infection prevention? Tom?
Yeah, so this one's going to depend on the facility and the sort of services being provided. But in general, again, we're talking about a lot of the same things. So improved hand hygiene is obviously going to be critical. So making sure supplies are readily available throughout the center, however it's laid out, so that there's alcohol stations frequently or hand washing stations frequently. And again, to be monitoring hand hygiene throughout, because as you come in contact with membranes or non-intact skin or contaminated equipment, all of a sudden you have another transmission issue. So again, PPE is really important. Don't wear the same gloves. Don't reuse wash gloves for reuse. I know some folks talked about needing to, really be cognizant of their supplies in some countries, in some parts of the world. But again, when we're talking of the singular focus of infection prevention, going through gloves and not reutilizing them is really important. Environmental surface cleaning, equipment cleaning. And again, if you're not talking about an operating theater, injection and medication safety probably take a bigger piece of the pie here, right? If you're using multi-dose eye drops, again, not making contact with the patient is super important, because now you're not just talking about contamination of a single patient, but cross-contamination. So if you're doing eye drops, all that hand hygiene that Dr. Goldstein just talked about is really important, but also not making contact with the eye, using single syringes to administer medication, reinserting needles into medication vials, and preparing medications away from the patient care area. These all become that much more important because you're not doing surgery. So all of that area of surgical infection control tends to kind of fall away because you're not doing those services. One of the bigger risks is injection and medication safety. And then again, just keeping potential exposures to a minimum, using respiratory hygiene, cough etiquette. Again, with COVID and other respiratory diseases, MERS, things like that, you want to make sure when you're face to face with your patients that everyone is kind of aware of the risks involved in being sort of that close to their respiration. So I think those are kind of the key takeaways there.
Excellent. Thank you, Tom.
And Lori, can I say something
Of
also back what he was saying? When you're talking about the eye drops and multiple dose vials, entering those or discarding SDVs, I think it's really important to speak with your staff and talk about self-reporting of a breach is so important, and you're not going to get in trouble. We really need you to be very aware of aseptic technique. And if you have a problem or you see something, you need to speak up. No one's going to be upset with you. We're all protecting patients. But if we don't have that culture of safety, you may have a problem.
That's how we learn. That's how we learn.
I wanted to say that in the last question too, whether it's the leadership and the monitoring. There's a tendency to want to cover up breaches or cover up problems. And the issue is that the cover up is often worse than the crime, right?
Right.
And so if you have a breach, maybe no one's going to have an infection, but you had a breach. And if there's not a willingness to open up and to learn and to improve at the individual level and at the leadership level, then you're sort of doomed to eventually having a catastrophe. And I think it's super important to have an open culture that fosters the desire to improve, because then you don't have a tendency then to try to hide your mistakes.
Right. It's so important. It's it's just we're here together. We learn from each other. It's really just a process. Even things like needlestick injuries. I've had a needlestick injury. It's just one of those things that has happened, and we learn from them, but we don't hide them. It's nothing to be embarrassed about or worried. It's just you approach it head on and you learn from it. So Class B autoclave. So the question was, is a Class B autoclave a must for use? I would say in ophthalmology, yes. So that we have different types of sterilizers. We have Class Bs, there are Class Ns, there are Class Ss. So basically a Class B autoclave, what those typically use are pre-vacuum settings, and they can be used on instruments that come in multiple parts. They have lumens in them, they're hollow. You can use them on pretty much anything. The steam penetrates well, but the key is that it's pre-vacuum. So that with pre-vacuum, you're using pumps that push air out of the chamber, those little alternating pumps, and that's how you get the air out and you get the sterilizing agent to meet every little crevice. Now, when you're working with sterilizers that are like say Class N, these are more gravity displacement sterilizers. You can use them, but they're meant for solid instruments, very simple solid instruments. You might find these in some of the dental offices. No lumens, nothing hollow, nothing multiple parts or things you have to take apart. You can't use them, these sterilizers. You don't have enough steam penetration to contact. So same thing with class S is somewhere in between. A class S is somewhere between a class B and a class N. But same thing, it's not meant for, these complex instruments. So I would say yes, so class B is certainly needed for ophthalmic instruments. Is a good practice to wash surgical gloves with lactated ringgers to get your excess powder off. Dianne, what do you think?
Well, I would say that current recommended practices are that we use powder-free gloves. I think that's really important. We see, we don't want to put any type of sediment or anything, into the surgical field. We're really concerned about TASS. We're really concerned about just irritation. So I think it's really, you just need to try to get the correct type of glove for the surgeons and for the assistants.
Thank you. Is it safe to re-sterilize phaco tubing? What do we think?
Basically, you always just have to go back to the manufacturer's instructions for use, and you're going to look at that tubing and look at the label that's on there. Most of the time, it is single use. If you have something that says that it is approved for reprocessing, then you must meet all of the parameters for reprocessing. So I would say just go back and look at the label, look at the manufacturer's instructions.
Simple, simple, simple. Absolutely. Is just prepping with povidone iodine enough for prevention? Should it be left on for a certain amount of seconds? Dr. Goldstein, could you give us a thought on this?
If I could share for 1 second.
Absolutely.
Lauren, and it's about, I think this is going to answer a few questions because there were a number of questions about betadine in there. So I wanted to just go back and, is it just enough? Well, there's all the other protocols too for infection prevention, right? It's the preoperative antibiotic drops that patients take. It's skin really should be cleansed before they even arrive to where they're going to have surgery. So that's all part of patient education as well. But I want to talk a moment about betadine because it's important that we understand that that is still the best alternative in ocular surgery for prepping the eye and the surrounding areas. So I put up, actually, I took this slide really right from the manufacturer's instructions for use, which is the way we try to do everything. And we understand that there's limited availability in some places. Because one of the questions that was asked is, how long does the betadine have to stay in? And I've been in practice for about 32 years. And I still come from a time when there was no such thing as phaco. So, and there's still, I guess there are still places doing it without phaco. But I understand that for as many times as I've seen eye surgery, there are as many different recipes to be able to prevent infection on how the eye is prepped. But the key here is to use betadine effectively. It starts working immediately, as it says in the slide, and it continues to working for some time afterwards. So I want to bring that out as well. And what it tells it to prep it about 3 times. There's specific instructions. Some people wipe it off with alcohol afterwards. I don't know that that's the best practice out there. Lori, you and Dianne, you probably will both be able to comment on that a little better. But the key is to let betadine work according to its instructions for use and allow somewhere between a 2 and 3 minute drying time. And if you do that effectively, along with the appropriate postoperative drops, or whether it be a postoperative antibiotic implant or an injection, those are what you do to prevent infection.
Yeah, I've always been taught just let it sit there and dry. Don't touch it, don't pat dry. That's the best that you can do for betadine effectiveness, but just to let it sit there and dry. Yeah.
I agree.
So infection protocol when you're recommissioning of an operating theater after renovations or prolonged closure. So Tom, Dianne, I think both of you had some thoughts on this.
Yeah, so I can start and just say, so construction is a pretty big risk because some of it's going to be environmental, again, depending on where you are, and humidity and all those things. Fungus can grow, and as we've seen from the cleansers, right? Some cleansers aren't fungicidal and some are viricidal. So you have to be very careful about how you're doing this. So one of the best ways to go about this, and one of the resources that we were looking to talked about putting in a risk assessment prior to starting the project, right? What are the environmental risks? What are the risks that you're going to face doing your construction or doing your remodel? in your center, given your location, because that's always going to be a component of this. So you should plan it out and approve your process before you even commence the work, and then obviously adjust as needed. So fungus has been a big known infection control risk from construction around the globe. Legionella, Listeria, and Aspergillus are common construction-associated health-acquired infections. So be aware of those and combat those health infections appropriately. You need to look at air quality, negative pressure, minimizing dust, using drop seats, sealing the areas, especially if you're going to be partially operating while a theater is being renovated. Changing air filters more frequently, really important. Flushing, the plumbing is going to be critical. So flushing water lines, looking for discolored water, looking for appropriate temperature, microorganisms, testing for microorganisms. And then obviously, again, if you're going to be partially in operation, making sure that patients have minimal exposure to any areas that are under construction. And then upon completion, you want to have, sort of a full terminal cleaning. You want to wipe down all hard surfaces. Mm-hmm. You want to, not just from an infection control standpoint, from a biomed standpoint, you want to recheck all your equipment. So all of your equipment that's been decommed for a while, you need to make sure that it is biomed tested and approved and that it's still calibrated appropriately, but then disinfect it and clean it up, and then re-sterilize supplies that might have still been in the areas is critical. So that's my quick one, because I'm sure Diane's going to give you some more info. The other thing I think is important, we found a good resource from Australia that was a government tool for utilizing construction. We provided that to CyberSite. It's attributed to the government in Australia. If you need that, I think it'd be a good starting point. Obviously, again, it may be geography specific, so you may need to adjust based on where you are, but it's a nice tool and a good policy for a starting point.
And may I also add as well is if you're moving your sterilizers, if you're having to do any repairs on your sterilizers, if anything during this, renovations or anything, these sterilizers, they just can't be put into use. Okay, we're back up running on Monday. Let's just start sterilizing instruments on Monday. You need to test those sterilizers before you put them back into use. You need to do
three times.
Thank you. If you're doing biological testing, you need to be testing those sterilizers, biological bug testing. If you're using, indicator strips 3 times, these sterilizers need to be tested before you're putting them back into use. You just can't stop back up again.
That's also an important note for even without renovation or prolonged closure. Mm-hmm. If you buy new equipment and you put a piece of equipment into storage and it was recalibrated before it went into storage and now you need to use it, maybe the new equipment broke down or is out for maintenance, or you've expanded and now have another theater and you're bringing that old equipment back into use. Just because it was good before doesn't mean it's good again.
Right.
And that needs to be tested, and the biomeds need to get involved, and sterilization of any equipment needs to happen again. So, recalibration is a key all the time in prolonged use and in disuse. It's very important that those sort of routines are respected.
And log it, document what you're doing, document that you've done this testing so we can go back and assure.
And retrain staff if you need to get them back into training. I mean, we've even seen ASCs that move locations. They have a new ASC building, so new construction, it's a big deal, and you want to roll it out effectively. Have a checklist, go through the checklist, make sure you don't miss anything. Yeah, it's a big deal.
Short cycles, suggestions for sterilizing instruments in long cases when you're utilizing short cycles. Dr. Goldstein?
I'm not going to talk much about short cycle because it is pretty unique to the ophthalmology world. Actually, what I've learned is there are short cycle sterilization, which is not immediate use sterilization. So I want to make sure that then we understand the distinction between the two. What I think we need to be very cognizant of, that short cycle is good for very specific instruments and have to be validated for that short cycle. It is not necessarily recognized by all regulatory agencies involved with infection control and sterilization. In the United States, it is recognized by CMS, which is the Center for Medicare and Medicaid Services, but it's not necessarily recognized by other infection control bodies such as AAMI and so forth. What I want to caution everybody about, which you can see up in the screen, is because I saw that a lot of the poll indicated that there's a lot of immediate use sterilization out there. And that to me actually throws a lot of caution in the wind. Immediate use, it's defined as the shortest possible time between items removal from the sterilizer and its aseptic transfer to the field. And an item that's intended for immediate use should never be stored for future use. So one of the suggestions that's come out as well, we don't have enough equipment to run our day. We're just going to use immediate use sterilization between cases because we can't do short cycle and we don't have enough time. It is an extreme red flag in the accreditation world. I could go back and show you, but one of the worksheets that we use, and we can supply that to CyberSite, and we ask a facility when we accredit them, is do you use immediate use sterilization, and what do you use it for? If you use it in 70% of the cases, that's not appropriate. That's got to stop immediately. So what I would tell people is you need to slow down between cases. You can only book the number of cases for which you can sterilize the instruments for. We look at immediate use sterilization very carefully, what processes occur, and in fact, the equipment needs to be appropriately manufactured for that use. So you can't use IUSSS, and you can't store items with it immediately. There are, however, some indications where you can use it. And we'll look for that. Obviously, in an emergency, if an instrument is dropped off the field, then by all means, go ahead and not use IUSS, return that item to the field, and then it needs to be sterilized appropriately with the manufacturer's instructions for use. It is everyone's responsibility to ensure that we do not use shortcut methods to provide care in our facilities. So I would say that is probably the takeaway. Short cycle is appropriate. Everything has to be validated accordingly because it's all about the drying time.
Gonio lens. So Diane, I can, either you or myself, either way, I know when it comes to, lenses that we're using, gonio lenses, anything we're using in laser procedures, I know that we do so many procedures back to back to back, and cleaning these lenses has always been a question, but really it all comes down to the instructions for use and your manufacturer's instructions. They're there to tell you what you need to do to clean these lenses. Typically it's some type of germicidal wipe that you're using. I know a lot of people do try to just tend to use alcohol wipes. It's really just a matter of whether the manufacturer says that's effective or not. So typically what I see for most lenses is germicidal wipes, but just be very, very cautious. These things are toxic to the cornea. So rinse, 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 and making sure that when you're using any type of, whether it's alcohol, germicidal wipes, or whatever the manufacturer is telling you to, be sure. Usually it's a multi-step process. Typically the first thing they tell you to do is wash these lenses with some type of very soft, gentle soap. Just regular, yeah, exactly, just regular, any type of soft soap that you can use first, just to get the goo off, to get the gonio gel off, and then it goes into, there's always a two-step process, then it goes into what you can do to clean it, to rid it of germs, and that's usually germicidal wipes typically, but you really want to go through the manufacturer's instructions for that and see what they're recommending. And also the instructions are not just for cleaning and making sure that you have proper cleaning, it's also to extend the life of these lenses. If you're using something that it's not meant to be cleaning them, you're going to break down often some of these lenses, and you can ruin them. And we spend a lot of money on our instruments. We want to make sure we're taking care of them the way the manufacturer has told us to. But just key is, if you're using these germicidal wipes, please be sure that you're rinsing, 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 and it's not going back on someone's eye. Allergies and iodine. I get this question so often in the operating room when patients come in with allergies and the difference between IVP dye and iodine. What can you use alcohol? So Dr. Goldstein, what's your idea?
Well, I think the most important question is whether there really is a betadine allergy, and that gets lost. The easiest thing to do is chart betadine allergy. It gets promulgated or it gets sent out through the whole facility, and everybody just shies away. You can't use betadine. You can't touch betadine. Actually, betadine allergy it usually comes from people who have had IV contrast dye, maybe iodine within that. And really true allergy to betadine is extremely rare. The problem is there really are not great alternatives to betadine in the ophthalmology world. Pretty much almost everything else is caustic to the eye. And so there have been a lot of different formulas out there of what to do. So what is recommended is that we determine is whether it's a true allergy. If it's just some slight irritation on the skin, that is not an allergy. And I think it's safe to go ahead and use betadine because that's the preferred choice. There are a lot of recipes out there using baby shampoo to cleanse the eye, the lids, the eyelids before surgery. It's well tolerated, could be diluted out of the eye, and in conjunction with antibiotic drops, that's used. Most of these other items are really quite caustic to the eye and should not be used. 3% PCMX, which is actually a scrub item that's being used recently to cleanse the eye, that is being used with some success, but there really is no good data out there and no great alternative. The key is don't make it up. Look what is potentially caustic to the eye and don't use that. Cleanse around the eye as best that you can, use antibiotic drops, but really determine if it's a true allergy. If it's not a true allergy, go ahead and use betadine.
Excellent. And we've gone through all of our questions. Thank you everyone for sticking with us. I did look at some of the Q&A questions. I think we've hit probably most of them. It is getting quite late, so I appreciate everybody sticking with us. One question I did see that came up, the last question I wanted to touch upon, I'm afraid I don't have much experience with it, is UV lights for cleaning in the operating theaters. And I don't know, Dianne, if you've seen this, or Tom, as far as UV lights and how well they do. I don't have much experience in that, so I'm wondering if you have any thoughts on that.
I don't really either, to be honest with you. I mean, I know that was a technology that we used to see in hospitals all the time, that it can be helpful, but no, I don't know that it's evidence-based. I don't know that it's an evidence-based.
Yeah, to my knowledge too, there was a big push toward UV, right, with COVID, right? Was the UV light was killing COVID. So to the extent that I have seen it in conjunction with all of these other infection control practices, right? I've seen it where folks were using the OR, they did their terminal cleaning and then did UV light to sort of have a belt and suspenders approach at killing COVID.
Well, it's kind of an old methodology. I mean, they used to employ it in hospitals all the time. It was an adjunct, but I don't know that it's anything that's evidence-based for, like, in addition to your terminal cleaning processes. Yeah.
Good. Thank you all so much. We have some great resources that we shared with you all today. So many forms and templates, infection control plans. Please reach out. Quad A is so helpful in their resources. There is some information here on the screen. If you want to get a hold of any one of us, you can certainly email Quad A. We're always happy to help. You can always email me as myself. I'm willing to share anything that I may have with you. Again, we're all in this together. And CyberSite and their consultation as well. So please feel free, if you have any nursing questions that you'd like to ask, you can always go on to our CyberSite and you can sign up to just send in something that you wish to have a consult with, and it'll come to me and I will help out in any way I can. Thank you all for our panel. Thank you for our wealth of knowledge. This was wonderful, and I appreciate everybody joining us today. Everyone take care and be well.
Thank you so much.
Bye-bye. Have a great day.
Bye.
Thank you.